I am Dr. Rabia Asli, and I am a fellow in advanced heart failure and transplant cardiology at Mayo Clinic in Rochester, Minnesota. I'm here to discuss our article entitled Hemodynamic Assessment of Patients Supported by Continuous Flow Left Ventricular Assist Device with and Without Heart Failure Symptoms, which will appear in the upcoming issue of Mayo Clinic Proceedings. Left ventricular assist devices, or LVADs, provide hemodynamic support for selected patients with advanced heart failure. More than 15,000 LVADs have been implanted in the United States, with more than 2,000 LVADs implanted annually. As a result of improved durability and survival, the eligible patient population has expanded to include less critically ill patients with longer support times. Therefore, the focus has now shifted towards identification and management of complications associated with long-term LVAD support. Resting and exercise hemodynamics of LVAD recipients are usually improved with lower mean pulmonary arterial pressure and pulmonary capillary wedge pressure, and higher cardiac index. However, complications such as right ventricular dysfunction, aortic regurgitation, arrhythmias, or pump thrombosis may lead to recurrent symptoms of heart failure. New or recurrent heart failure symptoms can occur in LVAD recipients as a result of right ventricular dysfunction, left-sided dysfunction, or both. Right ventricular dysfunction is considered the most common cause of recurrent heart failure after LVAD. The current study, we sought to investigate differences in invasive hemodynamic parameters and outcomes in patients with and without heart failure symptoms after LVAD implantation. We identified 294 adult patients with end-stage heart failure who received LVAD from March 2007 through June 2016 for either destination therapy or bridge to transplant at the Mayo Clinic, and were supported for at least 3 months with an LVAD. From this cohort, we identified 51 consecutive patients who developed new onset signs and symptoms of heart failure after LVAD following recovery from perioperative period. This group of symptomatic patients was compared to 50 LVAD recipients with resolved heart failure symptoms who had undergone implantation during the study period. All patients in both groups underwent right heart catheterization, either for worsening symptoms in the first group or for optimization of LVAD settings. Patient characteristics and outcomes, including all-cause mortality and right ventricular failure, were compared between the two groups. The median age at the time of implant was approximately 62 years, and almost two-thirds of patients were implanted in LVAD as destination therapy. Compared with patients with resolved heart failure symptoms, symptomatic individuals were older, more likely to be males, and more likely to have ischemic cardiomyopathy. The distribution of intermax categories, the frequency of concomitant tricuspid or aortic valve surgery at the time of implant, and the frequency of pre-operation RV dysfunction did not differ between the two groups. At baseline, before LVAD, no significant differences in hemodynamic parameters between symptomatic patients and patients with resolved heart failure symptoms were observed. After LVAD implantation, symptomatic patients had significantly higher right atrial pressure, mean pulmonary arterial pressure, and pulmonary capillary wedge pressure, but had similar cardiac output and cardiac index compared with patients with resolved heart failure symptoms. Improvement in these parameters before and after LVAD was significantly lower in patients with heart failure symptoms. Among symptomatic patients, the frequency of RV dysfunction was significantly higher compared with the asymptomatic group. The frequency of mixed RV dysfunction and increased left-sided pressures, which is suggestive of inadequate LV unloading, was seen in twice as many symptomatic patients. Finally, 76% of patients with resolved heart failure symptoms had normal hemodynamic profiles versus 39% in symptomatic patients. For clinical outcomes, the median follow-up time was 2.7 years. The primary endpoint of all-cause mortality occurred in 64% of symptomatic patients and 20% in patients with resolved heart failure symptoms. The time from the post-LVAD right heart catheterization to death was 2 years in symptomatic and 3.5 years in patients with resolved heart failure symptoms. The presence of heart failure symptoms was associated with significantly higher risk of all-cause mortality with adjusted hazard ratio of 3 and RV failure with adjusted hazard ratio of 6.2 as compared to patients with resolved heart failure symptoms, which was independent of other predictors. Symptoms of heart failure after LVAD were not associated significantly with stroke, gastrointestinal bleeding, or driveline infections. Previous studies have suggested that a significant portion of LVAD patients have abnormal hemodynamics, including elevated filling pressures and reduced cardiac index, despite the absence of symptoms or adjustment of the speed based on conventional echocardiographic criteria. Optimization of device speed based on hemodynamic ramp study has been shown to effectively unload the LV and normalize wedge pressure and right atrial pressure. In our institution, supported by the present findings, we have employed a stepwise approach for patients with recurrent heart failure symptoms and abnormal hemodynamics. First, echocardiographic guided adjustment of speed, assessment for presence of aortic regurgitation and RV dysfunction, and optimization of diuretic regimen is attempted. If these measures fail to alleviate symptoms, invasive hemodynamic ramp study is performed. Speed is adjusted to the level associated with normalization of hemodynamics, and the need for inotropic support is addressed. However, similar to the findings of previous studies, a percentage of patients remain outside normal hemodynamic range despite speed optimization and medical therapy. The deranged hemodynamics and greater mortality in symptomatic patients observed in this study does not prove that efforts to optimize hemodynamics are effective in LVAD recipients, but the documented improvements in hemodynamics that can be achieved certainly supports this approach. Further prospective study is required to test the value of LVAD optimization using invasive and non-invasive parameters. In conclusion, patients with recurrent heart failure symptoms after LVAD implantation display more profound hemodynamic derangements, greater burden of RV failure, and increased rates of all-cause mortality compared with LVAD recipients with resolved heart failure symptoms. These data suggest that detailed evaluation of the RV failure risk and preoperative hemodynamic optimization is vital for LVAD candidates. Thank you for listening to our discussion today, and we very much hope that you will enjoy our article.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.